Thank you for joining our webinar today. This is the fourth installation of the From Data to Practice webinar series. This one is focused on school health profiles and the 2019 YBRS school health data. Just as a reminder, this webinar is being recorded so we can share it out for folks who are not able to attend. It will be posted to the Alaska Children's Trust's webpage. This webinar series is a partnership between the State Department of Health and Social Services and the Alaska Children's Trust Alaska After School Network. We're thrilled today to turn things over to our presenters and one of our co-hosts, Gina, with the State of Alaska. And thank you all for joining us. Feel free throughout the course of the discussion and webinar today, put your chats and thoughts inside of the chat box. Also, feel free to use the question and answer box. We'll be at the end of the webinar, we'll get a chance to field some questions and comments from participants. So make sure that you're using that chat box feature and that question and answer feature. Thank you all. And again, the webinar is being recorded and we will share it out after the webinar is done. Thank you.
Thank you, Thomas, and thank you to the entire Alaska Children's Trust for hosting this webinar series. Thank you everyone in attendance today. The Alaska Youth Risk Behavior Survey, YRBS, is led by Dr. Andrea Finotti, and Taslima Mannix is the YRBS data manager. I've been with the team for 2 years. Through this series, we share results, as Thomas had said, from the 2019 YRBS and provide information on how these results are used throughout Alaska. Joining us today are the Healthy Schools Specialist, Patrick Sidmore, with new 2020 School Health Profiles survey results. The Alaska Oral Health Specialist, Frances Wise, with exciting new initiatives, and the Alaska School Nurse Consultant, Barbara Pennington, who will share how YRBS data have helped her important work and work that directly helps Alaska's students. We'll briefly introduce the YRBS and school health profiles, look at key results and trends from the 2019 YRBS and 2020 profile survey. Frances and Barb will tell us about what is being done in Alaska, and then we'll offer some time for questions. Our website may typically be found at yrbs.dhss.alaska.gov, but we're going to drop a direct link to the YRBS partner video in the chat box for you now. Please consider playing this partner video in waiting rooms, meetings, and events so that we may spread the word on how YRBS results are used in Alaska's communities and the importance of participation. The Alaska YRBS is provided through partnerships with the Department of Health and Social Services, or DHSS, Department of Education and Early Development, or DEED, other state of Alaska programs like the section of Women's, Children's, and Family Health, or WCFH, and tribal health and youth serving organizations throughout Alaska. We all share the goal of improving the health of our youth. Established by the Centers for Disease Control and Prevention, or CDC, and first implemented in Alaska in 1995, the YRBS is a school-based survey that collects important information about the health of Alaska teens, including health risk behaviors that contribute to social problems, disabilities, chronic disease, and even death. Alaska high school students take the YRBS every other year in odd-numbered years. Student participation is anonymous, voluntary, and requires written parental consent. The 2021 YRBS will be administered this fall in October and November. Alaska is an active parental consent state by law, which means that parents are aware of the survey, and we help by providing resources so they may make informed decisions. However, if there's a low parental permission form return rate, there could be a low overall response rate. Therefore, we work a little harder in Alaska to ensure we get good data. In fact, the return of the YRBS permission slips is critical to the success of the YRBS, and our partners help us in supporting the YRBS programs in our efforts. This past spring, YRBS social media ads were posted to the DHSS Facebook page. Through these posts, We hope to help school districts with collecting YRBS permission forms. If your organization has shared these posts, thank you for helping us get the word out. Another campaign will start in late July, so please watch for these posts and share widely through your social media pages. Through YRBS results, we can identify behaviors among youth causing the most important health problems, determine the prevalence of health risk behaviors, in particular emerging issues, assess how risk behaviors change over time, compare results geographically, and even identify health disparities. This helps Alaska in the development of programs, grants, community assessments, and improvement plans. Statewide and even local results are available if enough districts, schools, and students have participated. We provide results of the survey. Programs throughout Alaska use and interpret these results to better understand the strengths and needs of our youth. This helps inform strategies, policies, and programs that reduce unhealthy behaviors and improve teen health. School districts and schools can use YRBS results to consider how risk and protective factor measures impact academic outcomes, to develop priorities within their own school communities. These fact sheets, which are developed by the CDC from national YRBS results, provide insight to how risk and protective factors relate to academic grades. The YRBS data dashboards are especially useful for those of us who like data but are not perhaps data scientists. We'll share links to the Tableau public YRBS data for the traditional and alternative high school data dashboards. These may be used until our website is back online. At the end of the presentation, we can drop links to all the dashboards, which would include the district level dashboards. Most of the information in this presentation is taken from these publicly available data dashboards. To see a step-by-step video on how to navigate the dashboards, please check out November's CDPHP webinar series presentation at the link in the chat box. And if you need help navigating these dashboards or additional information, please feel free to contact us at yrbs@alaska.gov. The YRBS includes questions on the topics shown here, but this quarter's webinar focuses on 2019 YRBS traditional high school results organized under the other health topic in the data dashboards. There are additional measures related to school and school health organized in other sections of the dashboards, but we'll just focus on these 6 measures, which again are under the other health topic. Pat, I'm excited that you joined us today to introduce the School Health Profile Survey and new results.
Thanks, Gina. The School Health Profiles is a survey that's also done every other year in conjunction with the CDC, every other year opposite the YRBS. And what happens is that we survey about 170 school health teachers across the state in K-12, middle and high schools, but focused on teachers that teach middle and high schoolers, so not elementary schools. And then the principals at those schools, about 170. It's a sample that's selected to represent the state, and we have data going back into the 90s. And this is an anonymous survey, and it really focuses on 3 areas: curriculum, policy, health policy, and professional development opportunities for those health teachers. And we will be gearing up in the fall to put that survey back out into the field in the spring of 2022. So again, Gina has mentioned our websites are down here at Health and Social Services, but as soon as they're back up, the 2020 results will go up. But we're going to look at some of those specific ones related to our topics today. Gina, I think this is actually yours.
Sure. So just a reminder that school health profiles results, it does provide information that can help create change that leads to positive improvements on students' academic performance. Okay, Pat, back to you.
Thanks. So this is a busy slide. So I want you to take a look at it. And one of the things that is true about our state is that there are some differences in the experience and the length of service of teachers depending on the school type. So again, this is a survey of our health teachers in about 175 actually schools across the state. And that column on the left, that's high schools, okay? Schools that are 9th through 12th grade. The middle one, middle schools, traditional middle schools, might be 6, 7, 8, or just 7, 8, and then on the right, K-12 schools. And you can see this is showing the relative experience of those health teachers. So in our high schools, all teachers were at least in their second year of doing this work. But in our K-12, a third of the teachers were in their first year. And this is structural in how we staff schools in the state and our rural areas, which is really where those K-12 schools predominantly are. There tends to be a lot more turnover and having folks come in. But this informs us when we think about the experience and how we support health teachers with professional development. So I just wanted to give you a chance to take a look at that and see the relative difference between the experience of teachers by the school type of health teachers. Thanks, Gina. So this is another look at a similar sort of measure, and it's whether or not the lead health teacher was certified, licensed, or endorsed by the state as in health education. And you can see that 3 out of 4 of the respondents to the surveys in high schools, yes, indeed, were 4 out of 10 for middle schools, and then just 3 out of 10 for K-12. And then this looks at their background. And I think that what we see is in the high schools, traditional high schools and middle schools, which tend to be in more urban or hub communities, we see that the health teachers have specific experiences in health fields as part of their training, as part of their professional development. But when we look at K-12, 42% of those teachers are generalists, right? Education generalists. And it makes sense because in our urban areas, we get some economies of scale and teachers can specialize more. But in rural areas, they tend to have to be more generalists. And so this really gets to how we have to support those health teachers to make sure that they get the professional development and the curriculum support so that they can teach the health topics, the ones we're talking about today and others, in the most effective way. So this kind of leads into a little bit about what Barb will talk about later with all the great work that nurses do in our schools. And this is the percentage of those schools that we surveyed, again, by each type, high school, middle school, and K-12, and whether or not they have a full-time or a part-time nurse that's in their school. And you can see that close to 80% of our high schools have a full or part-time nurse, full-time or part-time nurse. Same for middle schools, but it's really less than 10% in K-12. And again, structural, but it drives how we're able to deliver services, health services in schools. And then this is because nurses and counselors are so crucial to being the conduit, the bridge to families. We see some of the differences in how schools are able to link families to health services. High schools and middle schools, 3/4 of them or more, for the most part, are able to really do that work, where it's harder in rural schools. And again, that probably gets back to where the nurses are. And I don't have the counselor slide to show you, but it's very similar in scope of where we have those professionals in schools.
Okay, and now it's Barb.
Hi, I am the Alaska State School Nurse Consultant, along with Wendy DeGraffenreid, who's part-time. We added her this year. And part of my job is to help school districts all over the state, even those without school nurses. So I was a school nurse in the Anchorage School District for over 20 years. And then I took on this position as a state school nurse consultant. And so, as you know, school nurses have been very busy this last year with COVID response. But wanted to show you this slide because this shows a little bit about what school nurses do in the state. And I want to say that we have added more school nurses this year. 6 districts that did not previously have school nurses have full-time school nurses now, and they use that with the CARES Act money. And fortunately, we have more funds coming in for that can be used towards increasing school nurses and counselors in schools. Part of the problem is we don't have the staff available in Alaska. There's a shortage of nurses, as you know. So I always encourage any nurses out there to apply to be a school nurse. We have openings in many areas of the state. So I would encourage, if you're listening and you have a friend who wants to do an amazing work in public health, this is the job. So this framework is something that we use with our national organization. Most nurses, school nurses are part of this. And it assists school nurses in districts in the provision of a healthy and safe learning environment. And my section, the section of Women's, Children, Family Health, which also Francis is a part of, supports me. And we have a federal grant that's called the Title V Maternal Child Block Grant that every state gets. And we use this YRBS data to help support what we do with that block grant money. So this is very important to look at this data. So school nurse practice is guided by a framework that you're looking at right now for 21st century nursing. And it provides structure and focus for the key principles and components of current day evidence-based school nursing practice. And it is aligned with the whole school, whole community, whole child model, which many of you have heard about that work in schools. Central to the framework is a student-centered nursing care that occurs within the context of the students' families and school community. Surrounding the student's family and school community are the overlapping key principles of care coordination, leadership, quality improvement, community and public health, and they're surrounded by the 5th principle, which is standards of practice. And we use evidence-based quality care to help our students. So next slide there. In an article with the National Nursing Organization, it shows that school nurses who use data to inform their work are better equipped to practice under this framework. And many of us do look at this data to guide our practice. And, you know, we're looking at our Alaska numbers also. So this shows an example of a school nurse's office, and it might look a little busy to you, but as you notice, there's a lot of good health promotion examples up there. And there's a little rack card on the side there that many health offices have access to a YRBS rack card. And I've actually used that. I was a nurse in middle school for a long time. And so I used that in showing students, you know, where we're at and, you know, looking at different rates and the students that have different types of chronic illnesses. So Gina, is this your slide, the next one? The one before that? Nope. Okay. But anyway, the YRBS does have little magnets and data that we can use to put in our health offices. And we do a lot of teaching too as school nurses. And this just shows some of the percentages. And like I said, I have used that. And many students come in while they're waiting and they want to read some health information. And some of them are a little bit shy to ask about some of those personal questions. And so this is kind of a really good guideline for them to know what's normal for, what our statistics are here in Alaska. So we use this data, the YRBS, to help support funding for school-based health centers. And I'm a project manager for some of the funds that come in from our OSMAP, which is the Office of Substance Abuse. And some of you might wonder what's happening with that marijuana tax money that's coming in. Well, part of it, the legislature allotted to be used for after-school programs and for school-based health, which is about 25% that's managed here in the Division of Public Health. And so I've been able to utilize some of that funding to help increase the school-based health center's ability to use some screening tools to look at risk factor screening like depression, substance misuse, and suicide prevention. And we're using it to help support increasing counselors in some of those centers. And training for school nurses happens for counselors too. On ACEs, we have Teen Speak, which happens in women's, children, family health, motivational interviewing, violence prevention. So we are working as a team to help support schools around the state in all of these issues that are addressed in the YRBS data. And the history of school nursing too in Alaska, we have been able to increase our numbers. As I was saying, we have approximately 210 school nurses in the state. We have 54 school districts. And as Pat had mentioned, due to funding, the smaller districts cannot afford to have, they can maybe only afford to have 2 teachers. And so having a school nurse or a counselor is extra. But I'm really excited that some of the average size, not the super rural districts, but some of the districts that have 300 to 500 students have been able to add school nurses this year. So that's pretty exciting.
Thanks, Barb. We really do appreciate our school nurses and how much they've done this past year. So I'm going to reorient you to the 6 measures that were introduced earlier. These again are listed under Other Health. So we'll start with the first measure, traditional high school students who saw a dentist for a checkup, exam, teeth cleaning, or other dental work during the past 12 months. Unless otherwise noted, the charts I'm going to show you are directly from the YRBS data dashboards, which may be copied into your own presentation and publications. This section has a couple of special analyses that we provided, and so I'll point those out. The CDC Division of Oral Health shared that oral health affects self-esteem, school performance, and attendance at school. YRBS results may be used to better understand preventive care practices and prevention efforts. The YRBS dashboards, that link that we sent you earlier, provide 2019 results and trend information from 2007 or the earliest available data point for the most requested YRBS measures. This table shows the percentage of students who saw a dentist, again, for a checkup, exam, teeth cleaning, or other dental work during the past 12 months, all students, and by sex, grade, age, and race ethnicity. Throughout this presentation, point estimates are presented, but if there's a visual inspection and you kind of look at those point estimates, it makes it look like, it seems like there might be a bigger difference between the 2 groups. We compare and evaluate those differences by checking that 95% confidence interval, which are highlighted in green in the YRBS dashboards here. For the entirety of this presentation, I've relied on confidence intervals, a conservative comparison. Additional statistical testing through a data scientist may show differences that are not captured in these confidence intervals. It's always important to check with a data scientist before drawing final conclusions. You can also check the CDC website for US results and look for differences between US and Alaska. So titles on the charts provide the wording of the question. Blue squares here with the blue line are all students. The gray line with gray triangles are female students, and orange circles are male students. The dashboards provide a table below the charts that indicates whether there's a significant long-term trend from either 2007 or the first available data point, which here is 2015, or a short-term trend since 2017. Note that there has been no change since 2015 overall by sex, nor by race. In charts showing results by race, please note that the gray line with gray triangles are white students and orange circles with the orange line denote Alaska Native American Indian students. So high participation rates provide an opportunity to view YRBS data by subgroups. This and the next chart were developed from information in the data table that I showed you earlier in the YRBS data dashboards. And here, remember that more is better. We can see that there's a significant difference by race, a comparison which provides an opportunity to improve education, supports, and interventions where they are most needed. Many measures offer an opportunity to compare Alaska's results to US results. And here we noted a significant difference between Alaska and the US in comparing all students. And there was a difference between Alaska and US male students. We can also compare Alaska's results to results from other participating states. Programs can consider evidence-based practices that were implemented in states with better results and determine whether similar practices can be implemented here in Alaska to help improve the health of Alaska's youth. This chart was created from YRBS results from other states. 39 other states included this question in their 2019 YRBS questionnaire. Again, more is better, and we can see that perhaps it may be useful to find evidence-based practices that are working well in states with enviable results. So Pat, were there any school health profiles that you can share?
Yeah, we had just in the last couple of surveys, there have been some questions around oral health. And you can see that the results are flat. So this was from the teacher survey. The blue line there is the percentage of schools that routinely use school records to identify and track students with a current diagnosis of oral health condition. So about a third, and then the same is true for the percentage of schools that provided referrals to organizations or health professionals not at school around oral health conditions. So this is something that we've just started to track. And we can see that again, this is high school, middle schools, and K-12s that serve 6th through 12th grade. About a third to 4 out of 10 are doing those two things.
Great, and we are very grateful for Frances Wise for joining us here today. So Frances, are you ready?
Yes, thank you. Thanks for having me. So I wanted to introduce myself and the oral health program really briefly. I'm Frances. I'm the public health specialist for the state's oral health program. And as a brief introduction to the program, we're located in the section of Women's, Children's, and Family Health. I'm in the same unit, the Adolescent Health Unit, with Barbara. So I actually do have engagement to address disparities in oral health of Alaskan teens. And for us, the YRBS is our first and best source of supporting data to inform our efforts to increase access to oral health care for Alaska teens. So the oral health program currently is supported by a workforce development grant. That's our full support. So our focus is in supporting and advocating for Alaska's oral health workforce. But this includes providing current and relevant data to improve oral health and access to oral health care in the state, and to support health literacy initiatives to achieve these goals. So these data support and inform the development of the Oral Health Action Plan as well. And that's our roadmap for the state and for our partners to focus and target initiatives in education and access to care for Alaskans. And so the Oral Health Program is advised by and it collaborates with the Alaska Dental Action Coalition, which I'll refer to as ADAC after this, but that's the acronym. The Alaska Dental Action Coalition is a multi-decade organization. We are very lucky in Alaska to have a coalition that has been active for over 20 years. And it's a multidisciplinary organization of volunteers that are representing Alaska's oral health and public health leadership. So these are oral health and public health professionals. And they're an instrumental partner in revision of the state oral health action plan and the targets and focus that the state and partners will be aiming for. So thank you very much, Gina. I'll briefly address the Oral Health Action Plan because that's in revision right now. The prior Oral Health Action Plan was put together in 2010. So we're looking at the next decade of the Oral Health Action Plan. And And for 2012 and 2016, that was the period that the prior oral health action plan covered. That section, a lot of those focus areas are carrying forward into our current action plan. We're still looking at workforce, recruitment and retention, and importantly, development of capacity for oral health professionals, which includes education and health literacy for their patient base, supporting care programs that exist and expanding on those and improving health literacy, and decreasing early childhood caries in Alaska. Early childhood caries in Alaska, of course, it is an ongoing concern. Usually the efforts are targeted towards 0 to 6, and we know that those efforts kind of carry through. It's one of those long-reaching initiatives that can start with small children and the results go into their adulthood. But adolescents, of course, are receiving around preteen and teen years, they're getting that second set, the adult dentition. So that is an area and a group that we want to address separately and focus on as well. The initiatives from the state and from the Dental Action Coalition that address adolescent oral health care are predominantly informed and supported by YRBS data. I've emphasized this before, I'll emphasize it again. This is a huge tool in supporting the initiatives that we're doing. And it supports us in researching and following evidence-based practices that promote health literacy and access to care in states that are reporting high percentages of teens focused initiatives in this slide, and then right before handing this back to the YRBS team, kind of focus in on what we're looking at in that oral health action plan and what our partners are supporting us in that are efforts that are specifically targeted toward adolescents. And these are the efforts that are supported by YRBS data. And the YRBS data actually lends an interesting spectrum and scope for, because as Gina's noted, the YRBS results being nationally comparable gives us the opportunity to model evidence-based projects, programs, and outreach that's successful in other states. And the YRBS data results are actually, they are demonstrating performance measures and success measures in states that have targeted programs toward adolescent health. And I know this because Alaska's in conversation with Utah and New Jersey. These are two states that YRBS results place in the top 10 of reporting states for annual adolescent dental visits. And these are states that have targeted programs. Utah developed a curricula for oral health literacy for teens. And we're exploring involvement in and use of this tool in Alaska because we can see the performance measures and the great results that the state is achieving with their program. Alaska is also working on an adolescent targeted oral health education, health literacy project that's unique to our state, but it answers a need that's recognized in many other states as well. So this is a resource that will be widely shared when it's available. Alaska is working to develop a multimedia campaign, including a culturally competent video that's inclusive of youth and teens, and children and youth with special healthcare needs. And we're targeting that age of adolescence that highlights the transition to independence and teens gaining ownership of their oral health care, how to do this, and what it's like in the dental office during that visit and during their care. And so I'll transition back to the YRBS team here. I'll be available for questions. Happy to share further information, especially about the Dental Action Coalition. It is really a very multidisciplinary group and very happy to have input and feedback, especially in this time of revision from public health professionals, from schools. We're very supported by school health nurses as well, which is wonderful. So I'll hand this back over to the YRBS team. Thanks.
Thanks, Frances. And I was excited to join join ADAC myself. So I look forward to working with you all even more. So it's exciting that YRBS results are being used to develop adolescent oral health programs. And I wanted to note that Frances talked about the comparable results to national results. And I think Pat can even share that school health profiles data are comparable to national results as well. So But orienting now to the next couple of questions, have a food allergy and have asthma. They were on the 2019 YRBS, but are not on the 2021 YRBS questionnaire, since there are other sources from where this information may be obtained. So right now, let's look at students who have to avoid some foods due to a food allergy. And this chart shows the percentage of traditional high school students who, again, have to avoid some foods because eating the food could cause an allergic reaction such as skin rashes, swelling, itching, vomiting, coughing, or trouble breathing. Please note that the scale ends at 40% to better show the difference. Since this question was asked twice in 2015 and in 2019, there are no short-term or long-term trends to show. Based on a quick review of confidence intervals in the dashboard tables, there is a significant difference between females and males in Alaska with a food allergy. Pat, have you noticed anything interesting in the 2020 profiles results?
Yeah, so we, one of the important things around food allergies is education for students, not only for the students that have food allergies, but for their peers. Because sometimes there can be teasing and stigma related to food allergies. But what we see here, breaking it out again by the different types of schools, is that between 40 and 60% of the schools are teaching about food allergies in a required course. A little more, again, in the urban and hub schools than in K-12.
Thank you, Pat. And then Barb, can you tell us a little bit more about food allergies and how it affects students in schools?
Yes. So food allergies are more common in young children than in adults. So the most common ones that we see in school are milk, egg, peanuts, tree nuts, fish, shellfish, wheat, and soy. Many of those children come into school with an allergy action plan that is written up by their doctor, and they could have emergency medications in school, like an epinephrine pen, Benadryl, so that if they do ingest any of those substances, those foods while in school, that we have staff that are trained to be able to treat that. So they do need emergency care. And we have several training programs that are available. They're actually available on the Department of Education website to train non-licensed staff how to give medications in school, including epinephrine. And many schools that have school nurses do stock epinephrine for those unknown allergies. Sorry, I have dogs. So they are able to give about 20 to 25% of people that have an anaphylactic action plan or anaphylactic reaction actually have never been diagnosed before with anaphylaxis. So that's why we like to have that available. And we do have a plan in the future. It does need legislative change to allow our medical director to write a doctor's order to have that in school, to have emergency epinephrine in school. But we're working on that so that schools without school nurses will be able to give epinephrine to unknown allergies. But those students that already have allergy action plans in place, they're allowed to, we can train those teachers and other adults to give emergency medication. But it is really scary for teachers because they're not medically trained. And so it is significant, that normally there's between 20 and 25% of students that do have some type of allergy that is considered, serious. So food allergies in school are the second most common chronic disease. Guess what the first one is? We're going to talk about that next. It's asthma. But also, as Francis talked about, oral health. Actually, oral health issues are actually responsible for the most absences of any of our diseases in school or chronic diseases. And many times that's overlooked in schools. So we encourage teachers to teach about oral health and prevention and brushing, and not only the health teachers, but food allergies are the second most common. And students can be the subject of bullying because of having a chronic illness like food allergies. And that has happened in school. Like I said, I worked in middle school, and it's very sad when sometimes we have had tables where kids that have peanut allergies sit at that table, and we encourage them to invite their friends to sit with them so they don't feel isolated at all. And teenagers tend to be less careful about following their allergy treatments, as well as our diabetic kiddos, as they get into that age where they're less compliant about everything. And so we have to be really careful in school about making sure, you know, if they go on a field trip, their EpiPens go along with them. So school nurses help train staff in how to manage students with food allergies and emergencies like anaphylaxis. And every year I would teach all of my staff how to use an EpiPen, because you just never know when you might have to help someone. And some people have an anaphylactic reaction and they need an EpiPen within minutes, or else their airway closes up. Gina, you're muted.
Well, then you didn't hear your thanks. Thanks, Barb. I appreciate that information on food allergies. The asthma measures provide the percentage of traditional high school students who had ever been told by a doctor or a nurse that they had asthma. And so this question was not asked in 2017, so we can't provide short-term or long-term trend. However, we did note that there was a significant difference between Alaska and the US in students who had ever been told by a doctor or nurse that they had asthma, overall and in male students. Again, these are statewide results, so there may be local differences not captured here. Pat, again, was there anything related to asthma in 2020 profiles results?
Sure. And this one isn't fully labeled. That's my mistake. This is about asthma, and it's in secondary schools where teachers try to increase students' knowledge about asthma. You can see over time, it's really only occurs in about a third of our secondary schools. It's been flat during the last 10, 12 years.
Thanks. And Barb.
So as I said earlier, asthma is the most common chronic disease besides our oral health issues in school children in Alaska and the US. And the school nurses help to teach the staff about asthma, monitoring the students' medications, communicating with parents, connecting them to local medical resources. And the percentage of children varies from region to region in Alaska that have asthma, with some of our interior regions having a higher percentage because of environment and being inside a lot in the winter, not because of the cold climate. So it's one of the leading causes of school absenteeism. And it's also, when someone has an asthma emergency, it's also very anxiety provoking for our teachers in school. I've many times been called down the hall with my emergency bag for a student that couldn't breathe, having an asthma attack. And so the state allows, the Board of Nursing and the legislature allows in our state that students can carry their emergency inhalers, their albuterol inhalers, as well as their EpiPens, as well as their diabetic meds with them for these emergency conditions. But we do a lot of teaching. Again, that's one of the subjects that most school nurses teach the teachers about, because sometimes there's undiagnosed asthma, especially in our young children, our middle school age children. Sometimes they think they've outgrown it. And so we teach our teachers what to do in case of emergency, what to do if they don't have an inhaler, how best can you get that child to start to slow their breathing down, and when to call 911. You're muted, Gina.
Sorry, I had the dog in the background and the phone ringing, so keep muting now. Thank you, Barb. I've been learning a lot about food allergies and asthma through this presentation, so I appreciate your input. We'll look at measures now related to adequate sleep and homelessness. So I keep thinking 8 got 8. In a classroom of 30 traditional high school students, 8 students got 8 or more hours of sleep on an average school night. That was 25.6%. And here we can also see students who did not get 8 or more hours of sleep, which was 22 students in that traditional high school classroom of about 30 students. In US results, there was a decrease since 2007 in students who got 8 or more hours of sleep. Barb, what can you share from school nurses?
This is one of the issues we deal with so much. We have teachers that send the students down. If you can go to the other slide again. They come down because they're not paying attention in class. You can advance the next one. They're not getting enough sleep. They're not paying attention. Their head's going down. So we have to have a chat with them. Many times, the children who do not get enough sleep are also at high risk of other chronic illnesses like obesity, diabetes, injuries, poor mental health, problems with attention. And so the children, usually we do a little assessment with them and sometimes have to call the parents because many times electronics are what's going on in those children's lives, that they have their phone on during the night, they're texting someone, they're online, and parents are not aware of that. So parents that are able to monitor that, I think the kids are getting much better sleep. But there's been many studies done about the importance of getting enough sleep, especially as a teenager. They need as much as toddlers do. And we have frequent classes that the school nurses get trained in and how to talk to students about sleep deprivations and what's going on. But many times this is a big issue in school, and the way that the kids are able to stay on task and academic performance too.
Yeah. Thanks. So now we're also looking at another traditional high school classroom of 30 students. We found that 11.6%, or 3 out of 30, had ever slept away from their parents' or guardians' home because they were kicked out, ran away, abandoned, or felt unsafe in their home during the past 12 months. In a classroom of 30 traditional high school students, 3. Pat, do you have any insight on this risk factor?
Yeah, I mean, I think that, that sort of adversity is really impacts the stress response system that we know through all the adverse childhood experiences work and the tremendous trauma engaged schoolwork that's happening through the Department of Education. Anyway, this is a slide over time, again, of health professionals in secondary schools, or health teachers rather. And it shows the percentage that have been receiving professional development around emotional and mental health. And this is driven really by 2 things, just a lot of grassroots effort around this topic, but also some legislative efforts. A very similar, actually a little steeper curve can be shown on suicide prevention for teachers as well. So it's definitely rising to the top, and teachers are receiving a lot of professional development on the topic.
Thanks, Pat. And Barb? Oh.
Sorry. School nurses do play a vital role in addressing the health needs and improving opportunities for students to succeed. Many times it's either the counselor or the school nurse who first finds out that a student is homeless. Maybe living, buddied up with another family. Maybe they're living in their car because they're coming in tired. They haven't eaten, they haven't had breakfast. And so we can do some intervention. And most school districts do have a child in transition program, or we can connect those families right away to get some resources and get bus passes and get food and get, if they need backpacks. So we connect them with a lot of resources, including getting in the list for some stable housing. And many times those students come into school too without regular health care. So we can connect them to the Denali Kids Care program, give them resources for that, as well as other medical care.
Thanks, Barb. So the dashboards provide us that 9.7% of traditional high school students were tested for an STD during the past 12 months. Earlier in this presentation, we said that when there's a data-related question, consulting with a data scientist is really important. So here, the YRBS data manager, Taslina Mannix, provided us a closer look and found that among students who were currently sexually active, that is, had sexual intercourse with at least one person during the past 3 months, 1 in 5, 20.3%, were tested for a sexually transmitted disease. With a closer look at YRBS results, our partners in education, prevention, and healthcare can use this information to communicate with families and help improve the health of Alaska teens. And Pat, school health profiles.
Yeah, you can see over time that we've had a slight decrease in health teachers in secondary schools who've been working to increase students' knowledge about sexually transmitted diseases. So about 2 out of 3 right now, teachers are reporting that they're covering that topic. It's different again by the breakout of high school, middle school, and K-12. With the K-12 again being more rural, less likely to be able to cover that topic. And again, probably a structural issue with the training of those teachers and their access to curriculum. And then finally, this is what teachers said whether or not they would like to receive it, which are the blue columns, on whether they received training around STD prevention. And you can see in high schools, we've mostly met the need, but in middle and K-12 schools, the teachers there are really hungry for training in this topic, and so far we haven't met that. So we're definitely going to be using this and targeting that in our professional development planning. Oh, finally, I had one more slide, sorry. And then this is just where, again, that outreach to families around HIV and STD and teen pregnancy prevention. We really have a lot of work to do. Schools are not doing that outreach, probably to the level that we would hope for. And really not much different by school type.
Sorry.
That's okay.
Okay, Barb.
Right, and so many of those health teachers do have guest speakers that come in that can cover those subjects because of their lack of knowledge, and it's just great to have an expert to come in to talk about some of those subjects concerning sexually transmitted infections. So in Alaska, we do have a fairly high rate of sexually transmitted infections. Our website is currently down, so I can't give you exact data on this, but our rates have fallen in the last 5 years, but chlamydia and gonorrhea are still really high on the charts compared to other states per our population, per 100,000 population. And 8th grade is actually in many schools the last time that they get required health curriculum. And so being that there's that jump between 8th grade and high school, where they probably really need the knowledge. I think that's an area that we can really grow in and teach our students. And the school nurses do have a lot of information in their offices for students that come in and want a referral and have questions about sexually transmitted infections.
Thanks, Barb. So we've covered all the measures in the other health section of the YRBS data dashboards and learned about differences by race and between Alaska and the US in students who saw a dentist within the past 12 months, that more Alaska female students than male students have a food allergy, more students in the US than in Alaska have asthma, all students and in males. 1 in 5 traditional high school students who were currently sexually active were tested for an STD. 8 got 8, 1/4 of students got 8 or more hours for sleep, and more than 10% were homeless. Barb.
So I'm not sure what you wanted me to cover on this, sorry.
But just summing up, Barb covered health curriculum, policy, professional development, and some partner-led efforts. And Pat, thank you for covering that strong health literacy does improve youth engagement or teens engagement with their oral health care. New oral health strategic plan is, I'm sorry, did I say Francis? I hope I said Francis. There's a new oral health strategic plan in process, and I'm excited about that for adolescents. And you can join the Alaska Dental Action Coalition listserv at the address there. And then Barb covered annual school nurse trainings on oral health and dental emergencies, encouraging school nurse to collect data on students with yearly dental exams. And so now we're open for questions.
Great. And thank you everyone for your presentation today. Thank you, Gina, Barb, Francis, and Pat. We greatly appreciate you joining in on the call. We did have a couple of comments and chats in the box. Gina, this one I think would probably be fielded towards you. One of the slides early on was looking at the data breakout for white, Alaska Native, and other student populations. There was a question regarding, is there no data for African American students? Pat gave some answer to that, but thought you might maybe be able to jump in around demographic breakdown for YBRS data.
Yeah, that's a great question. And, you know, I keep saying the words, and I know I must sound like a broken record. High participation rates give us good data, right? Because if we don't have, and I'm just going to get to the table, we have data suppression requirements, right? So if we don't have enough to be able to provide a minimum of 100 responses in any subgroup, we can't report out for that. And if you want it broken down for female and male, there have to be at least 100 male and 100 female. So in our communities, I would just say we hover around, I think about a 60% participation rate by students, which is good, right? But we can get better, and we can encourage students to complete the survey, return them so that we can have better representation, because this is something that all of us would like to see. We'd like to see this subgroup breakout to be able to be reported. And again, we have those data suppression rules because the survey is anonymous and we can't provide data on groups that could be potentially identified.
Thank you, Gina. There was also then a question in regards to the comment around the active parental consent and the kind of intent of the law, and when maybe if you can clarify when that went into effect around that.
Sure. I have a history document. It was like late 1999 or so. Pat, do you have any recollection? I have it written down, but I'm afraid I don't have the memory to share it immediately.
My suspicion is Patty Owen, who was listening in at least earlier, probably could put it in the chat if she'd like.
Yeah, I think she contended with that. And so I don't wrestle with whether or not it's active or passive consent. I just respond to what the law is, right? And so again, we have to see the good news. The good news is parents know what's going on. They know the questions their students are being asked, and we provide a lot of support to make sure that schools and districts are successful, so that we can, yeah, that's what I thought, Patty. I think there were some articles in 1999 and some recommendations. Yeah, so 2000 is what Patty said, and she actually was the YRBS coordinator back then, right, Patty? Can we show her video if she lets us?
I don't think we can because of the Zoom webinar.
Okay.
And then Gina, maybe on, and again, anyone's welcome. Please put any comments or questions in the chat. I do see another one coming through. Wondering on recommendations for continuing to create solid, healthy relationships with school districts as a nonprofit who's providing a large quantity of health curriculum standards. So any recommendations, maybe this is for Barb or Pat, any recommendations for those community partners, Barb, like you were mentioning, especially for STI partnerships and education, what are ways that they can help foster that relationship with districts?
I would say just probably conversations with their school board and with superintendents and principals, letting them know your availability, and usually any changes need to be approved by the school board. So, but just as much as you can have those communication lines really open and being available. We all have concerns about health curriculum and making sure our students are getting the right information as they move into adulthood and as teens. So hopefully it helps. Pat, do you have anything to add?
Yeah, I was just going to say that many school districts use some specific tools related to developing health curriculum that includes input from the community, and you can encourage that or take a look at that. And if you have questions about that, I'll put my email in the chat, and you can certainly email me, and I'll get you some information about that.
Great, thank you, Barb and Pat. Well, we are down to the last minute here. In the chat box, Anna did put the link to our next webinar, which will be the next From Data to Practice webinar, September 23rd on adolescent health. Also, please make sure that you are doing the workshop evaluation. This helps us strengthen and improve the webinar series for future webinars. Just again, want to thank our presenters, Gina, Pat, Barb, and Francis, for all your work that you've been doing across the state to advance adolescent health and the well-being of our schools and students. So thank you. And if you'd like to ask any other questions, we're going to go ahead and just stay online for a moment longer, and we will close the Zoom room here at about 1:02.